for blood product preparation, okay, so first is the blood collection procedure, okay, or so the blood donation proper itself. So you can have whole blood donation or apheresis or automated donation. So what is the difference? The only difference is that for apheresis donation, you will need the use of your apheresis machine. Okay? While for whole blood donation, ito yung diretso from the donor. Okay, so you will insert it. It's either a single bag. Okay, it's a single bag or a multiple bag blood donation. Okay. So for the procedure, we will not elaborate more on this kasi you will be experiencing this during your internship. Okay. However, if you will work as a medical technologist, it is an advantage if you will get a phlebotomy certificate from the Philippine Blood Coordinating Council. Okay, so they have a module or a training for phlebotomy. Okay, uh, specifically for blood donation. Okay, let's proceed to the second one, which is your blood product preparation or component preparation. Blood product preparation or component preparation. 5 minutes. Okay, sorry for the interruption again. Okay, so for blood product preparation and component preparation, so under this, okay, will be the first one is component preparation from whole blood. Okay, so ito yung madalas na ginagawa natin. So there is a diagram in your notes. So there is a flow chart, I mean, in your notes, okay, that we will follow. So from whole blood collection, so say for example, you have already your whole blood, okay, from the donor. Okay, so the first thing is, are we going to filter the blood? If yes, okay, we call that the filtered whole blood. Okay. If no, okay, the first The first component to be produced will be platelet. Okay, so platelet manufacturing. So if yes, okay, we proceed with okay. We proceed with soft spin. Okay, we proceed with soft spin, and then with the soft spin, you are able to separate the red blood cell and the platelet-rich plasma. Okay, so you are able to separate the RBC and the platelet-rich plasma. So now the RBC, if you add an additive, okay, you can add an additive if desired. Okay, yung mga adsol, yung mga ganun, those are additives. And if you're going to filter it, okay, you call that your filtered RBC. If not, you can store it as a packed red cell at 1 to 6 degrees Celsius. Ganun din yung filtered RBC. Okay? With the platelet-rich plasma naman, you proceed with doing a hard spin, okay, on the platelet-rich plasma. And then from there, we will express the plasma, tatanggalin mo yung plasma, to get the platelet concentrate. And then let it rest for 1 hour, and then store it at 20 to 24 degrees centigrade. Okay. For platelet concentrate, okay, so platelet concentrate, kailangan mo ng at least 4 donors to come up with 1 unit of platelet concentrate. Okay? So kapag kunwari merong pasyente na nangangailangan ng platelet, ang ginagawa is antayin mo munang mabuo yung 4 na donors. Okay? I-bleed mo sila ng sabay-sabay, and then you can proceed with the processing after. Hindi pwedeng mauna si donor 1, susunod si donor 2, susunod si donor 3, tapos followed by your donor 4. Dapat sabay-sabay yun para sabay-sabay na magawa yung isang platelet concentrate. Okay? So store that at room temperature and with continuous agitation for how many days? For 5 days. Okay? So for 5 days. Pero there are studies wherein they call that the extended platelet concentrate up to 7 days, but for the purposes of your exam, ganyan, it is only up to 5 days. The express plasma naman, okay, your plasma, you freeze the plasma immediately and store it at negative 18 degrees Celsius or colder. Okay, it can be negative 60, negative 65, depending on the need or depending on the availability of your freezer. Okay, so we end there. And then let's proceed to the whole blood again. Okay, so sa taas, whole blood filtration, if no naman, or if you are not going to, if you do not need the platelet concentrate, we proceed with a hard spin. Okay, the whole blood will undergo hard spin to separate the RBC and the plasma. Okay, and you can add an additive. So for RBC, ganun din, yung parang kanina, do you want to filter the RBC? If yes, you call that your filtered RBC. You store that at 1 to 6 degrees Celsius. If no naman, you do not need to filter that. It's still a packed red blood cell and stored at the same temperature. For plasma, ganun din. So the separated plasma coming from a hard spin will be processed as a fresh frozen plasma and store that at negative 18 degrees Celsius or colder. If you want to do a cryoprecipitate from a fresh frozen plasma, okay, if you need to thaw. Okay, so ito thaw natin yung FFP at 4 degrees Celsius. Okay, so pwede mo siyang ilagay sa ref, hindi sa freezer, sa ref lang, and then you do another hard spin of the thawed plasma and express the cryopore plasma. Okay, tatanggalin mo yung plasma part, and what is left will be what we call your cryoprecipitate. Okay, so if you want the cryosupernate, it's the plasma coming from the FFP that has undergone hard spin. Okay, So, yun. And then you have to store that at negative 18 degrees Celsius or colder. Okay? Don't worry, in the succeeding page, in the succeeding parts of your handout, nandito yung mga blood products and we will go to them by one by one. So actually, mahirap kasi siyang intindihin if you are not working in the laboratory. Mas maganda pag nakikita mo to and you have been doing this every time, almost every day, hindi mo na siya kailangang i-memorize. Pero for the purpose of your exam later on, for your board exam, you have to follow this algorithm. And the second one is your component preparation by apheresis. Okay, so again, it is, as we have mentioned earlier, okay, so you will be subjected to, your blood will be processed using an apheresis machine. And then the component that is not needed or yung component na hindi natin interest, babalik din lang sa katawan mo. So the principle is separation by specific gravity. Okay? So there is an illustration in your handout wherein it says there that specific gravity for platelet is this 1.040, yun nakalagay dyan. Okay? So based on the specific gravity, mahihiwalay mo yung iba't ibang components ng blood. Okay? And then, kung ano man yung makulit mo, edi yun yung, kung ano yung kailangan ng pasyente, yun lang yung i-collect natin. Okay? Any questions before we proceed? Okay, let's ask Maika. Maika Butak. Maika, are you with us?
Yes, Doc.
Mm-mm. Pag tinanong ka, say for example, diba, nasa inyo ka, tatanungin ka ngayon ng mga kamag-anak mo. Say, kung kunwari, merong kayong kamag-anak na nangangailangan ng dugo. Tapos tatanungin ka ngayon ng mga kamag-anak mo kasi alam nila na nakaputi ka, alam nila doktor ka, or alam nila na medtech ka. Kunwari kailangan ng isang kamag-anak mo ng platelet concentrate na 2 units. Anong masasuggest mo sa kanila? Whole blood collection or apheresis?
Doc, isuggest ko po yung yung whole blood collection.
Bakit? Bakit yun ang masasuggest mo?
Doc, kasi onti lang po yung units na kailangan po.
Kailangan mo. Pero, ilang donors ang kailangan mo? Ilang blood donors ang kailangan mo?
2 lang, 2 din po.
2 lang. Sabi natin kanina, kapag gagawa tayo ng isang platelet concentrate na mga ilang volume na ang platelet, mga nasa 60 to 70 yun eh. Check lang natin. Platelet concentrate from RDP. Mga 60 to 70 ml. Kailangan natin ng 4 donors para makabuo ng isang platelet concentrate. So sa 2 units, pag whole blood collection, kailangan mo ng 8 donors. Nakuha?
Yes.
Yes, nakuha mo? So kailangan mo ng 8 donors. So ipoproceed mo pa ba na isa-suggest ang blood ang tawag dito, ang whole blood donation?
Hindi na po siguro.
Hindi na. Ano na, apheresis na. Apheresis na ba?
Pwede po, pero depende pa rin po siguro sa pag-donatan ng platelet.
Like, anong ibig mong sabihin? Anong depende sa pagdodonitan?
Yung decision po nila. Pero pag wala pong enough na platelet na 8 units po, pwede pong mag-undergo na lang ng apheresis.
Hindi, 2 units lang kailangan niya. 2 units lang ang kailangan ng kamag-anak mo or ng pasyente. Pero ang kailangan mo talaga 8 donors para makabuo ka ng 2 units. Bakit hindi na lang apheresis? Kasi 1 donor, makakaproduce ka na ng 6 to 8 units. Or kung hindi ganun ka-successful, mga 4 to 6 units ng platelet concentrate. Anong final answer, Micah?
Dok, kung para sa akin na lang po, yung ano na lang po, yung whole blood. Kahit,
Whole blood.
opo. Tapos
Kahit
yung,
8 units.
opo.
Okay, so, okay. Actually, wala namang tamang sagot dito, no? Walang tamang sagot. Depende yan sa circumstances. Depende yan kung nasaan kayo. Okay, so tawa siya. Nabanggit niya kanina kung depende kung anong desisyon, depende kung ano, kung kunwari may apheresis machine. Okay, so unang-una, may apheresis machine ba sa area? Pangalawa, yung cost. Okay? Kapag ka apheresis machine kasi, by apheresis mo kukunin yung platelet, gagastos ka ng mga 25,000. Mas makakamura ka kapag ka, tawag dito, kapag ka whole blood donation kasi mga gagastos ka lang siguro ng mga 10,000. Okay? So malaking difference. Okay. But later on, you will know the advantages naman and disadvantages of doing apheresis, okay, versus whole blood collection. So we will go to that later. Okay, let's move on to the components derived from whole blood donation and apheresis. Okay. So number 1 is whole blood. So we will just go through it. So medyo babasahin lang natin. So please take a hand of your notes, okay, so that you can follow. So whole blood, whole blood is an unprocessed blood containing all cellular and plasma components of donor blood. So in terms of volume, it is 450 ml plus minus 45, as we have mentioned earlier, excluding the anticoagulant, which is 63 ml. Okay. So for the specifications and quality control, itong mga to, specifications and quality control, kailangan itong ma-maintain para sabihin natin na safe yung blood at saka acceptable siya. Okay, acceptable. So the hemoglobin must be at least 45 grams per unit. Okay, so kapag chinek mo yung blood, pag in-spin mo siya sa capillate, dapat ang hemoglobin niya ay 45 grams. Ang hematocrit naman niya ay 0.35 to 0.45. Kapag 0.30 yung hematocrit niya, maganda ba yun na whole blood? Okay, obviously the answer is no. Okay? So dapat yung hematocrit niya is within the range of 0.35 to 0.45 per unit. The potassium should be less than 27 millimoles per liter, and the plasma hemoglobin should be less than 0.04 grams per liter. And in terms of sterility, there should be no growth. Okay, question. Why do we need to monitor the potassium level of your whole blood? Okay, let's ask again, Luis Sabado. Why do we need to monitor the potassium level? Luis, are you with us? Hello, Luis, are you with us? Okay, sige. Let's just proceed. Okay, so we have to monitor the potassium level of this whole blood because any excess of potassium will lead to cardiac arrhythmias once transfused. Okay, so magkakaroon ng mga arrhythmias sa pasyente, ay sa recipient na tatanggap ng dugo. Okay. In terms of storage and expiry, the storage should be from +1 degrees Celsius to +6. Okay. And in terms of expiry, if the anticoagulant is CPD, up to 21 days. But if we are going to use CPDA1, so yung may adenine, up to 35 days. Most of the hospitals or most blood service facilities will use CPDA1. Okay? But if you are going to add additive like Adsol, it can be extended up to 42 days. Okay? So if the blood is irradiated, okay, 28 days from irradiation or the original expiration, whichever comes first. Okay. So depende kung 28 days from irradiation or kung kunwari mas maaga yung expiration niya, kung ano yung mauna, yun yung susundan natin. Okay. In terms of dosage, if you give one unit of whole blood to a patient or to a recipient, the hemoglobin will increase by 1 gram per deciliter and the hematocrit will increase by 3%. Which means that, say for example, a patient has a hemoglobin of 8, okay, and you want to increase the hemoglobin by up to 10 grams per deciliter. How many units do you give or will you be giving this recipient? Okay, so you need at least 2, okay, 2 units of whole blood. Okay, let's proceed to the packed red blood cell. So this is a component obtained from the removal of most of the plasma from whole blood by sedimentation or centrifugation. Okay? So yung bakit sedimentation? Kasi yung ibang mga laboratories or ibang blood service facility na walang refrigerated centrifuge, ni-stand nila yung blood for at least 8 hours or more to get the to get the packed red cell and express out the plasma. So the volume is 280 ml plus minus 50 ml with the same hemoglobin as your whole blood, and the hematocrit is from 0.65 to 0.75. Bakit mas mataas na siya? Because tinanggal mo na yung plasma. Okay? So mas na-concentrate, kaya siya mas na-pack yung red blood cell, kaya mas mataas yung kanyang hematocrit. In terms of the potassium naman, okay, potassium should be less than 78 millimoles per liter. And the plasma hemoglobin should be less than 0.65 grams per deciliter. So we have also to maintain the pH at more than 6.5. Okay, hindi pwedeng maging acidic or else mamamatay yung mga red cells. And sterility, there should be no growth, okay, of the, walang growth dapat on culturing. So in terms of storage, it is same as your whole blood. Okay. In terms of dosage, pareho lang with whole blood. Nowadays, okay, most of our clinicians will not request anymore for whole blood apart from trauma. Okay? So in cases of trauma, ang pinakamagandang ibigay will be whole blood. Pero other procedures, other surgical procedures, dapat packed red blood cell.
Office, we would like to extend a warm welcome to all of our participants here in
Packed red blood cell ang binibigay. Okay? Next, we proceed with the Buffy coat poor red cell. So it is a component prepared by the separation of the plasma and Buffy coat from the red blood cell. Buffy coat removal decreases the formation of microaggregates. In terms of volume, it is 250 ml plus minus 50 ml. In terms of its specifications and quality control, the hemoglobin is lower at 43 grams per unit. In terms of hematocrit, pareho lang kasi it's still considered a packed red blood cell. Okay? But the Buffy coat is removed. Okay? In terms of potassium levels and in plasma hemoglobin, same as your packed red cell, and the leukocyte unit is should be at 1.2 times 10 to the 9. Why is this so? Because you remove already the Buffy coat. The Buffy coat contains your WBC and your platelets. So dapat mababa yung kanyang leukocyte count. In terms of pH, same as your whole your packed red blood cell, and in terms of sterility, pareho lang. No growth din. In terms of storage, same lang, similar lang. Okay? Bakit hindi na siya irradiate? Because mababa na yung kanyang WBC. Ang purpose lang naman ng WBC ay ng irradiation is to radiate the WBCs para hindi siya, ang prevent kasi natin dito is yung prevent kasi natin dito yung transfusion ng CMV. Okay? Inaatong natin yung CMV. Kaya hindi na. Next, wash red blood cell. Okay, so it is a red cell suspension prepared by removal of plasma by centrifugation and subsequent washing of red cells with pre-cold NSS. So here, we wash yung red blood cells, okay, para maging wash red blood cell. However, in actual practice, dapat hindi na to ginagawa. Okay, so pang academic purposes lang, wash red blood cell should not be anymore be used in the clinics. Why? Because it is very prone to contamination and bacterial overgrowth. Okay. So, in terms of volume, it is 250 ml plus minus 50 ml. In terms of hemoglobin, mas mababa na siya. Hematocrit, same lang, 0.65 to 0.75 kasi it's still a red cell component. In terms of the protein content, it should be less than 0.5 grams per unit. Why? Because you have already washed the plasma component and you have washed the plasma component. Kaya the protein naman kasi is present within the plasma. That's why mababa na yung kanyang protein component. Okay? In terms of storage and expiry, same. Please take note, it is stored at 1 degrees to 6 degrees Celsius, but it should be used within 6 hours after washing. Why? Because if you would use this more than 6 hours, it is very prone to contamination and bacterial overgrowth. In terms of dosage, same as your packed red blood cell. Okay. So again, this is just for academic purposes, your washed red blood cell. Okay, so bawal na daw yan gawin sa para naibigay sa pasyente. Next is your leukocyte-reduced packed red blood cell. So it is a red cell preparation where majority of the leukocytes are removed. Okay? Pre-storage filtration within 48 hours after collection is recommended. Okay. Pero meron tayong tinatawag na bedside filter. So this bedside filter will also produce a leukoreduced packed red blood cell. Para siya, yung leukoreduce ay yung filter na yun, yung sinasabi kong bedside filter, ikakabit mo lang yung unit doon dadaan yung dugo papunta sa pasyente. So mafi-filter out na yung leukocytes para matanggal. Okay? Bakit natin kailangang tanggalin yung leukocytes? Kasi may mga reasons. Okay? So number one, yung leukocyte kasi will induce febrile non-hemolytic reactions. Second, you will decrease the transmission of your CMV or your cytomegalovirus because your cytomegalovirus are intracellular organisms. Okay? So in terms of volume, 270 ml plus minus 50 ml. In terms of its hemoglobin content, yan, 40 grams per unit. And the hematocrit can be from 0.5 to 0.7 p. And the residual leukocyte is lower at less than 1 times 10 to the 6 per unit. So kanina dun sa Buffy coat poor red cell, mas mataas pa rin yung leukocyte count niya. Pero dito kasi sa leukocyte reduce, talagang gagamit ka na ng filter to reduce the number of leukocytes. In terms of storage, pareho lang. But if this leukocyte-reduced packed RBC is done open system, it is stored or it must be transfused within 24 hours. In terms of the dosage naman, similar lang. 1 gram per deciliter per unit. Okay? So any questions with our whole blood and red cell components before we proceed? Five-minute break, sorry. Okay, let's proceed. So let's proceed to FFP. So FFP or fresh frozen plasma This is the non-cellular fluid portion of the anticoagulated blood, which has been extracted from a single donor unit within 6 hours post-collection and rapidly frozen to -13 or -18 as described in the algorithm a while back, or colder. Okay. So in terms of volume, it is 200 ml plus minus 50 ml. And take note of the following. For quality control and specifications, so we have to monitor the factor 8C level, or factor 8, which is more than 70 international units per 100 ml. So for a regular FFP, 1 unit of regular FFP, meron siyang 200, so times 2, 140 IU per unit. Okay. Kasi ito times no 200 ml. Okay. And the residual red cell should be less than 6 times 10 to the 9 per liter. Okay. And platelets should be less than 50 times 10 to the 9 per liter. And there should be no leakage, no abnormal color or visible clots. So -65 -65 degrees or below, you can store the FFP for 7 years. -40 degrees Celsius to 64, 2 years, down below. Okay? Nandito. Pero dati, ang FFP kasi, during our time, okay, when I was a resident, up to 6 months lang. Okay? To 6 months lang. Pero pwede mo daw yan extend. Depende sa temperature kung paano mo siya store. So it increases factor by 20 to 30%. Anong factor yon? It's your factor 8C. Okay? So it increases your coagulation factor 8, 20 to 30%, 20 to 30% per 10 ml to 20 ml per kilogram. Okay? So for the cryoprecipitate naman, as you have seen earlier, so cryoprecipitate is a product from an FFP, di ba? Yung FFP na itoto mo, tapos hard spin mo ulit. Okay. So the component that contains cryoglobulin, which is a fraction of plasma obtained by further processing of FFP prepared from hard spun cell-free plasma. So sa cryoprecipitate naman, maliliit lang yan, less than 15 or equal to 15 ml to 25 ml. And it contains factor 8C at more than 80 IU per unit, fibrinogen of 150 milligrams per unit, and your von Willebrand factor at more than 100 IU per unit. Okay? So yan. So pag mga bleeding may mga bleeding tendencies, mga ganyan, naka-ready na dapat ang FFP and cryoprecipitate. In terms of storage, it has the same storage as your FFP, and it increases fibrinogen 5 to 10 ml per kilogram. Okay. Let's proceed to your platelet concentrates. So your platelet concentrates is divided into two. You have your platelet, random donor platelet, and your single donor platelet. Pag sinabi nating random donor platelet, ito yung nakukuha from multiple donors, from whole blood collection. Pero pag SDP, ito yung galing sa single donor by apheresis yan. Okay? So let's proceed first to your RDP. So platelets suspended in a small quantity of plasma prepared by centrifugation of whole blood units within 6 hours post-collection before refrigeration. Okay? So in terms of volume, plus minus 60 ml plus minus 10 ml. So around 60 to 70 ml. Platelet count should be at least 5.5 times 10 to the 10. Okay? So this is a common board exam question. What is the platelet count of your RDP? So 5.5 times 10 to the 10. And the residual leukocytes before depletion is less than 0.2 times 10 to the 9 per unit. And the Buffy code should be less than 0.05 times 10 to the 9 per unit with a pH of 6.4. So here for platelet concentrates, dapat monitor lagi ang pH because they are very sensitive to pH changes. Pagka nag-change kasi yung pH, medyo masisira, ay madali silang masira. Okay? And in terms of storage, they are stored at room temperature in continuous agitation for 3 to 5 days. So they increase platelet count by 5,000 to 10,000 per 5,000 to 10,000 per unit yan actually, per unit. Okay? So kunwari meron tayong patient na merong 100,000 lang na platelet count. Gusto nating ma-achieve yung 150. So ilan ang kailangan natin na platelet concentrate na RDP? We need at least 5. Okay? 5 units times 10,000 kasi yun yung per unit equals 50,000. So from 100,000 to 115,000. Unlike for platelet or for single donor platelet, okay, so these are platelets suspended in small quantity of plasma prepared by automated instrumentation, or so this is your apheresis. So in terms of volume, it is 250 ml to 300 ml. Why? Kasi mas madaming units ang mapoproduce dito. So kung kunwari yung kanina, 60 ml yung RDP, ito mga kung 300 yan divided by 60, mga 5 units. 5 units kaagad na platelet concentrate ang makukuha sa isang donor. Okay? In terms of platelet count, it is higher at 3.0 times 10 to the 11. Again, another board exam question. What is the platelet count of your single donor platelet? Residual leukocyte, yan, and the pH should be maintained at 6.4 to 7.4. In terms of storage, pareho lang. And in terms of the increase in platelet, it is from 30,000 to 60,000 per unit. Bakit ganun kataas? Kasi mas madami siyang laman. So itong nauna, yung RDP, isang unit lang yan. Ito, 5 units in one bag. Okay? Kaya mas mataas yung kanyang pag-increase. So plasmapheresis product, okay. So itong plasmapheresis, FFP lang din naman siya, pero ginawa siya by apheresis. Okay? So yun lang naman yung difference nun. Same as your packed red blood cell by apheresis. So same as your whole blood, pero it was prepared by apheresis. Granulocyte concentrate or leukapheresis. Okay, so most of the time, we do your granulocyte extraction by apheresis, and the volume depends on the harvested product. So it can be from 200 ml to 600 ml. And in terms of the leukocyte, it is also variable, okay, ranging from 55 to 300,000 leukocytes. In terms of storage, it is stored at room temperature with continuous agitation until immediate transfusion, and it is can be subjected to irradiation. Why do we need to irradiate? Again, remember, you have your granulocytes, okay, wherein they can harbor your CMV. That's why we need to irradiate them. So in terms of the dosage, this is the dosage, but we are not using this anyway in the clinics. Okay. Another important thing to note here is the RBC frozen or frozen RBC and the glycerolized RBC. So red blood cells frozen, suspended in a cryoprotective agent or your glycerol to be stored in a long period of time. Okay? Before it is used, it is deglycerolized and free from plasma and leukocyte. So, ang ibig niyang sabihin, upon storage, ilalagyan mo ng glycerol. Pero kapag gagamitin mo na, i-deglycerolize mo para matanggal yung free plasma and leukocytes. In terms of volume, 180 ml lang of packed red cell na glycerolized. And in terms of specification, 80% RBC recovery. Bakit 80% lang, hindi 100%? Because pwede siyang masira during the processing. During processing, baka nasira na yung ibang red cells, kaya 80% lang. And the glycerol should be less than 1%. In terms of storage, it is stored at -65 for 10 years. Okay? So bakit ko to ine-emphasize? Because later on, baka mag-abroad kayo and you will work as a medical technologist in a blood bank, ginagawa itong procedure na to. I have an intern before. Okay? He is now working at Johns Hopkins Hospital, one of the best hospitals in the world. Okay? So nasa blood bank siya. So yun, ginagawa nila tong frozen RBC. It is used for rare blood types. Kung gusto mo mag-store ng rare blood types, mga ganyan. Kasi pwede mo siyang store for 10 years. And in terms of its dosage, yan. Pareho lang din sa mga packed red cell, whole blood, and the rest of the red cell products. Okay, do you have questions? Before we proceed, okay, let's proceed first to your blood products and indication for use. Saan nga ba ginagamit itong mga blood products na ito? Okay, so let's begin with fresh whole blood. Okay. So in some, kapag nagtrabaho na kayo later on, may mga sasabihin nila, gusto ko yung fresh blood. Anong ibig sabihin nun? Ano ang ibig sabihin ng fresh blood? Usually daw, ang fresh blood ay 3 days old. Okay? 3 days old na blood. Pag day 4 na siya, hindi na siya considered fresh whole blood or fresh blood. Okay? So ang fresh blood daw ay 3 days old na. Pinaka-maximum na yung 3 days. Okay? So usually used in evident massive blood loss and coagulopathy. Okay? So ginagamit siya in massive blood loss. So example will be in trauma. Okay? So usually binibigay na whole blood. Trauma casualties but only when specific blood products are not available. So ang ibig niya sabihin dito, ang sinasabi dito, they still advocate for component therapy. Kung pwedeng packed red cell lang ang ibigay, packed red cell. Pero pag hindi available, talagang point blood. But there are some surgeons, okay, na they still prefer whole blood over packed RBC in cases of trauma. Or in hemorrhagic shock, or in neonatal exchange transfusion. Okay. In neonatal exchange transfusion, kailangan mo kasi yung plasma and the red blood cell. Okay. So open close parentheses here, there is what we call your reconstituted type O. Bakit ginagawa yung neonatal exchange transfusion? Ginagawa yan sa mga ABO-HDN. ABO-HDN. Wherein, ano ang ABO-HDN? Sinong pwedeng sumagot? Ano ang ABO-HDN? Anyway, ang ABO-HDN, magkaiba yung blood type ng mother. Okay, tsaka ng baby. Okay. So ang gagawin dyan, kapag magkaiba sila ng blood type, ang gagawin is magkakaroon ng exchange transfusion. Okay. Wherein you will need blood type O. Okay. Yun ang ginagamit, blood type O, or pwede kang gumawa ng blood type O mo. So ano ang ibig sabihin ng reconstituted type O? Reconstituted type O is you will get a plasma from an AB positive donor and the red cells of an O positive donor. Because remember, yung AB positive na donor, wala siyang antibody. Tama? Tapos yung antigen naman ay yung O na packed red cell, wala din siyang antigen. So paghahaluin mo ngayon, okay? So wala siyang antigen, wala din siyang antibody. That's why it is the best type of blood given for neonatal exchange transfusion. Okay? Safe na safe ka doon. Next, for packed red blood cell, okay, if the hemoglobin is less than 10 grams per deciliter, okay, it is best to give packed red blood cell. Why not fresh whole blood? Because the patient can go into circulatory overload. Kasi hindi naman niya kailangan yung plasma, kailangan niya lang yung red blood cell. Kaya yun yung ibibigay mo. Disabling angina pectoris. Ang angina pectoris is chest pains. Okay? Kasi chest pains, yan. Bakit packed red cell? Ganun din. Kasi pag nag-circulatory overload, dahil madaming plasma na kasabay, okay, pwede ulit mag-chest pain yung pasyente. Even in myocardial infarction. In myocardial infarction naman, the heart is very weak. That's why hindi mo na siya pwedeng pag-working mag-work na malakas. So dapat easy-easy lang yung pag-work ng heart, kaya dapat packed red cell lang ang ibigay mo. Congestive heart failure due to severe anemia, pareho lang. End-stage renal disease, yung mga naghihemodialysis, and not indicated during chemotherapy. Okay. Bakit hindi mo binibigyan ng PAC-RBC ang pasyente na chemotherapy? Kasi daw, yung cause naman ng pagkaroon ng anemia ng isang pasyente is due to yung drugs. Okay. So once you remove the drug, dapat bumalik yung kanyang red cells. Okay. However, in extreme cases, nagbibigay pa rin ng packed red blood cell kapag masyado nang mababa yung hemoglobin ng pasyente. In surgical cases, if the blood loss is 2,000 or 40% of the blood volume. So pediatric indication are the following. Hemoglobin level of less than 8, 10, with tachycardia, poor weight and feeding. Hemoglobin level of less than 130 grams in acutely ill neonates with cardiorespiratory disease. Hemoglobin of less than 18 in stable but symptomatic neonate, and neonates and premature infants associated with shock or sepsis. Okay? Basta tandaan nyo, in pediatrics, okay, hindi gumagamit ng whole blood. PAC-RBC lang yan. Tapos nakakompute yan per body weight. Okay? Depending sa weight ng patient. Hindi kagaya sa atin na 1 unit. Hindi. Sa kanila, 50 cc per kilogram, mga ganun. Or 1 ml per kilogram body weight. Ganun. Depende sa component na ibibigay. Washed red blood cell, as I mentioned earlier, it is not already being used in the clinic, but okay, it is used previously in confirmed deficiency of IgA. Ito yung mga IgA deficiency. Okay, that results to severe allergic reactions, recurrent severe allergic type adverse events, okay, so binibigyan ng wash RBC, or paroxysmal nocturnal hemoglobinuria. Okay. For leukocyte-reduced red cell naman, these are given in immunocompromised patients due to the risk of CMV and transfusion-associated graft versus host disease. or TAG-VD. Okay? So, na-mention ko na kanina na kapag ka may WBC, pwede siyang i-irradiate or gamitan ng filter para matanggal mo yung CMV. Okay. So, immunocompromised patients, example of this will be yung mga transplant patients, kidney transplant patient, heart transplant patient, mga ganun. Lahat ng transplant patient, usually, ay dapat binibigyan ng leukocyte-reduced PAC-RBC. Okay? And also for long-term red cell support to prevent recurrent febrile non-hemolytic transfusion reaction. Okay, so we will go to that later on. After hematopoietic cell transfusion, a transplantation with severe aplastic anemia. Okay. Fetal or neonatal transfusion. Leukocyte reduced. Okay. In irradiated blood components naman, it is given for recipients of intrauterine transfusion. Yung baby, habang pinagbubuntis ng mother, tinatransfusion and binibigyan ng trinatransfusan. So dapat ang gamitin doon ay irradiated blood red blood cell. Or kapag napanganak na siya tapos nagtutransfuse pa din, neonates who have previously received intrauterine transfusion should also receive irradiated blood components. And patients with congenital immune deficiencies, Hodgkin disease, or receiving purine analog drugs, recipient of stem cell or bone marrow transplants, patients with aplastic anemia receiving immunosuppressive therapy, recipients of directed donations from family members, and recipients of HLA-compatible single donor platelet and granulocyte transfusion. Okay? So dun sa second to the last, please take note, recipient of directed donation from family members. As I mentioned earlier, di ba, dapat dinidiscourage na natin yung directed blood donation because it is very prone to transfusion-associated graft versus host. Pero kung hindi maiiwasan, the best thing to do is to irradiate the blood components at 25 grays. Okay? So merong machine na nag-i-irradiate. So yung radiation na level is measured in grays. So dapat 25 grays. Pero in milligrays, minsan, minimeasure siya in milligrays. So it is given a radiation dose of 2,500 milligrays. Okay. Let's proceed to RDP, or random donor platelet. So it is given for ongoing massive bleeding to maintain a platelet count of more than 50 times 10 to the 9. CNS trauma or bleeding to maintain a platelet count of more than 100,000 times 10 to the 9. In patients with massive blood transfusion and weak platelet count of less than 20 times 10 to the 9. Episodes of hemorrhage during treatment of severe thrombocytopenia, aplastic anemia, and myelodysplasias. Mucosal bleeding persists in patients with hemolytic disorders. Adult patients receiving therapy for acute leukemia at threshold of 10,000 units per liter. Patients with solid tumor receiving aggressive therapy and with necrotic tumors to maintain a threshold of 20,000. And patients with qualitative platelet dysfunction with bleeding. Okay? So karamihan ng mga bleeding tendencies, bibigyan mo rin ng RDP. Pag SDP naman, halos pareho lang. Same lang yung kanyang indication. Pero tandaan nyo ito. Maganda tong It is indicated for repeated platelet transfusion to prevent platelet refractoriness. Ang platelet refractoriness is an event wherein bigay ka ng platelet con, pero napansin mo, hindi tumataas yung kanyang platelet count. Okay, ang tawag doon ay platelet refractoriness. So sayang lang yung binibigay mo na ano. This happens in random donor platelets. Okay? So nangyayari siya sa random donor platelet. So paano mo siya ipa-prevent? Maggagawa ka ngayon ng or magbibigay ka ngayon ng SDP, single donor platelet. So yung question ko kanina dun sa classmate nyo, kung ano bang ibibigay, kung tawag dito, kung paano siya magdo-donate ng platelet, kung RDP ba or SDP. Okay. So nabanggit natin kanina, depending on the availability of machine, depending on the availability of blood donors, ganun, kung ilang units, the cost, ganun. And the third one, and the other reason for giving RDP or SDP is if the patient has already platelet refractoriness. Okay? So, mas magandang mag-SDP ka na. For FFP, okay, so multiple coagulation factor deficiencies or single coagulation factor deficiencies. But remember, for FFP, ang meron lang naman siya ay factor 8C. Okay? So, usually, binibigay lang siya pagka may ganong factor deficiency. So, bleeding secondary to hemorrhagic disease of the newborn, neonates with coagulopathy, for neonatal exchange transfusion, AB or type-specific FFP, severe bleeding due to warfarin toxicity, open heart surgeries, and trauma. Okay? For cryoprecipitate naman, fibrinogen deficiency, as you have seen earlier, and DIC with bleeding. Okay. So, yan. So, yun yung indications ng mga iba't ibang blood components. Okay? So, hindi na, although magiging medical technologies kayo, hindi naman ibig sabihin na hindi nyo alam yung indication. Dapat alam nyo din para ma-monitor nyo kung tama ba yung mga nire-request ng mga doctors. Because if not, okay, kung mali yung ni-request nila, pwede nyo naman silang sitahin through your pathologist. Okay? Pwede nyo siyang i-report sa pathologist nyo na, ay, si ganito po, parang mali yung kanyang request. Okay? Any questions before we move to adverse reactions in blood transfusion? So I believe you have already discussed this during your blood bank subject in third year. So marami pa tayong i-discuss, kaya let's proceed. Okay. So what are the adverse reactions in blood transfusion? Okay, so the first one is okay, let's proceed first to risk of transfusion. So for transfusion, it is a generally very safe procedure. And yun nga lang, okay, it is safe when you have already screened that for transfusion-transmitted infection. Okay? But can also be, you can also screen them for non-infectious transfusion reactions. Or I mean, risk of transfusions can be due to TPIs, non-infectious transfusion reactions, and transfusion-related fatalities. Okay? So second is recognition and evaluation of transfusion reaction. So clinical recognition is very important. So sino ang makakapag-recognize if there is a transfusion reaction? Johanna? John. Ano to? Diogana Faith. Diogana Faith. Are you with us?
Yes.
Mm. In your opinion, who can recognize clinically if there is a transfusion reaction? Is it on our part or part of someone else? Or the role of other departments? Tayo ba ang nakakapag-recognize kung merong transfusion reaction? Ano? Sino ang nakakakita kung may transfusion reaction? Sino ang may responsibility to look at, to look if merong transfusion reaction, hemolytic or non-hemolytic?
Possible. Kasi with some doctor monitoring you what you and yet in the ward there's only one nursing aide.
It is the responsibility of the clinician or the nurse, okay, in the wards. Kasi syempre nakahook na yung blood doon, hindi naman na natin nakikita kung while the transfusion is ongoing. Okay? So, upon clinical recognition of transfusion reaction, be it a hemolytic or not, you should stop the transfusion. Okay? Dapat stop the transfusion and then we perform a laboratory investigation. So we will check for pre-analytical errors, analytical or post-analytical, and perform primary testing on post-reaction sample. So we will get blood from the patient, urine, okay? But this urine you will not check for, you will not subject this for urinalysis. You will check for the presence of hemolysis. Okay? Report findings to the transfusion service physician and perform additional testing service as per transfusion physician order. So this happens, itong mga to, report findings, perform additional testing. Okay? These are done in the wards, okay, but not in the laboratory. Okay, so what is our protocol for basic testing of post-transfusion reaction sample? Okay, so first, the very most important thing to do is to do a clerical check. Check on the following. Okay, check the following information if this matches. So first, post-reaction sample. Okay, again, urine and blood. Transfusion documents or documentations and the blood bank when it is available. Okay. If there is no discrepancy, let's check for hemolysis. Okay. So a visual check for free hemoglobin will manifest as a pink or reddish discoloration in the plasma, even in the urine. Okay, so makikita mo na parang color pink siya, baka may hemolysis. If walang hemolysis, okay, so let's proceed as so. Third, you perform direct antiglobulin testing, so detect the presence of red blood cells that are sensitized in vivo. Okay? So pag nagkaroon ng antibody reaction, antigen-antibody reaction. If negative, okay. If negative for DAT or your Coombs test, notify the transfusion service physician. Okay. And of course, you will perform another ABO testing. So pag walang discrepancy, so pag may discrepancy naman in terms of the clerical error or clerical check, notify the transfusion service physician. So if another patient is involved in discrepancy, take necessary steps to prevent another adverse event and go to secondary testing if requested by transfusion service physician. For hemolysis check naman, pag positive siya ng hemolysis, pag hemolysis is present, request for draw. Okay, so magdodraw ka ulit ng blood. Okay? And if the hemolysis is present on the second draw, notify the transfusion service physician and go to the secondary testing if requested by the transfusion physician. Pag yung DET naman ay positive, notify the transfusion physician and go to secondary testing if requested by the transfusion the physician. Pag may discrepancy sa EBO, request for redraw, and if discrepancy is revealed, notify the transfusion service physician. If another patient is involved in discrepancy, take necessary steps to prevent another adverse reaction. Okay. So ito yung pinakaunang gagawin, post-basic testing in post-transfusion reaction. So later on, or nung nag-aral kayo, nung pinag-aralan nyo ito nung third year, baka meron yung B1, B2 testing, meron yung hemoglobinuria, yung dipstick na hemoglobinuria, yung mga yon. Okay, so these are the secondary testing. Okay? Only if it is requested by the physician. Any questions? Okay. So dito sa in my practice, ang pinaka-common na identify namin is a non-hemolytic transfusion reaction. Okay? Febrile non-hemolytic transfusion reaction. Okay? Never pa ako naka-encounter ng hemolytic transfusion reaction.
Symptomatic yes po. May I ask our cluster yes, what
Okay? So, do you have questions for the adverse reactions in blood transfusion? Hindi pa tayo tapos, mag-proceed pa tayo. Okay? Okay, so let's have a 10-minute break before we proceed. Okay, so I will see you at 2:30. Okay, we continue. Okay, so let's proceed to non-infectious transfusion reactions. Okay, so these are non-infectious kasi hindi sila TTI related. Okay, so the first one is alloimmunization to RBC antigens. So alloimmunization, as I've mentioned earlier, it is where when you receive an antigen that your body reacts to it and produces its corresponding antibody. Okay, so that's that's alloimmunization. So for this particular type, you are in an RBC antigen is introduced into the recipient's system, and the recipient reacts to it. So development of non-ABO antibodies following RBC transfusion, pregnancy, and transplantation. So it may complicate patient care and increase the risk of acute and delayed hemolytic transfusion reactions with higher alloimmunization in chronically transfused patients. An example of which is in hemodialysis patients wherein they receive multiple units of blood, be it whole blood, packed RBC, or whatever, and they develop alloimmunization. That's why most of them will have dun sa cross-matching incompatibilities, be it major or minor. Okay? So, dun namin na tinatanong, we ask if these patients receive multiple transfusions. Okay? So if yes, okay, we will just inform the attending physician and they will sign a waiver, and the transfusion will still, the transfusion can still push through. Okay? So the recipient response is varied. It can be hyper-responder or late responders. Okay, so recognized as incompatibility during cross-matching. Okay, so as I mentioned earlier, it can be a minor incompatibility or minor incompatibility. In some institutions, they do not already perform minor cross-match. Okay? So question, let's ask Regine. Regine Velasco, are you with us? Regine?
The thing is, yung ano lang, basta may ma-recognize din, ma-assess agad. But
Regine, are you with us? Naku, wala na atang tao. Okay. Well, anyway, as I mentioned, yun, in some institutions, hindi na ginagawa ang minor cross-match. Okay. Bakit hindi na siya ginagawa? Kasi wala naman ng bearing. Kahit pa +4 yung grade ng minor incompatibility, still you can proceed with your transfusion. It will not already matter. Okay. However, for not like for my major cross-match wherein if you have a reaction of 2+ or more, it is already clinically significant. Okay. Acute hemolytic transfusion reaction. So here, there is accelerated destruction of transfused RBC due to antibody-mediated incompatibility. So acute meaning you have combination of signs and symptoms associated with hemolysis, biochemical evidence of hemolysis, and serologic evidence of RBC incompatibility during or within 24 hours post-transfusion. Signs and symptoms may vary from fever to DIC to death. Okay, so the most common cause is ABO incompatibility. Okay, so dito yung acute hemolytic transfusion reaction, as mentioned, is the most common cause is ABO incompatibility. Okay, so problems with blood typing ito. Okay, so instead of this particular blood type, say for example, type A ang ibibigay sa patient, type B yung maibigay. Kung AB, okay lang. Although meron transfusion reaction, pero hindi ganun ka-severe. But if you give another blood type like type B, then the transfusion reaction will be very severe. Okay? So, yun. So the transfusion, the signs and symptoms may vary. It can be fever, it can be DIC, it can be shortness of breath, it can be bleeding, yun. Okay? So iba-iba ng transfusion reaction. So the most important thing to note there is, the most important when doing blood transfusion is clinical recognition of a transfusion reaction. So you have to stop that immediately and then perform your post-transfusion reaction. Okay. The third is delayed hemolytic transfusion reaction. Delayed hemolytic and serologic transfusion reaction. So, this is defined as positive direct antiglobulin testing or your direct Coombs test, 24 hours to 28 days post-transfusion with evidence of hemolysis from 7 to 10 days. So evidence of hemolysis can be an inadequate rise in hemoglobin or appearance of spherocytes. Okay? So kapag nag-PBS ka, makakakita ka ng mga spherocytes. Or pag nag-check ka ng blood ng patient, hindi tumataas yung kanyang hemoglobin. Okay? So those are evidences of hemolysis. Delayed serologic transfusion reaction is a delayed hemolytic transfusion reaction without evidence of hemolysis. Okay? So pag may hemolysis, sabihin mo delayed hemolytic transfusion reaction. Pero kapag walang hemolysis, you call that delayed serologic transfusion reaction. Okay? So the most frequent signs are hemoglobinuria with painful crisis and acute chest pain. So akala mo nag-myocardial infarction yung patient, hindi pala. Nagkakaroon pala siya ng hemolytic transfusion reaction. And the most common cause are the D, the C, the E, and the U. Okay? Or basically your RH blood group, which includes your D, C, and E, and your U blood group. Okay. Next is transfusion-related acute lung injury or what we call your TRALI. Okay, TRALI. So it is a diagnosis with clinical, and the diagnosis is clinical with no diagnostic test. So si clinician lang or si doktor lang ang makakadiagnose nito. It is a diagnosis of exclusion. Dapat natanggal niya lahat ng or na-rule out niya lahat ng impossible causes of acute lung injury. Okay? So there is a criteria for your acute lung injury. So number one, absence of acute lung injury prior to transfusion. Dapat si recipient wala pa siyang acute lung injury prior to transfusion. Next, acute lung injury during or within 6 hours after transfusion. Third, evidence of hypoxemia by blood gas or oxygen saturation testing. Okay? So upon checking your EBGs, nagkakaroon ng hypoxemia yung patient or yung O2 sats niya ay bumababa. And radiographic evidence of bilateral pulmonary edema and exclusion of circulatory overload. So these are the evidences, okay, or the criteria for you to diagnose a TRALI. Okay? So in the laboratory part, hindi naman tayo makakapagsabi ng TRALI. Okay? Yung mga clinicians ang makakapagsabi ng TRALI. Okay? So the cause is anti-human neutrophil antigen and anti-HLA antibodies. Okay? Anti-human neutrophil antigen. Okay, so anti-human neutrophil antigen and anti-HLA antibodies. Okay. Non-antibody mediated TRALI exists, and this is due to platelet neutrophil interaction. Okay. Platelet neutrophil interaction. Number 5 is transfusion-associated circulatory overload or your TACO. Okay, so magkaiba yung TACO at yung TRALI. So it is an acute respiratory distress syndrome caused by increased intravascular volume due to excessive transfused fluid. Masyado daw madaming fluid na na-transfuse. Pwedeng whole blood, pwedeng FFP na madami. Okay. So at least clinical criteria. So acute respiratory distress, dapat meron yung pasyente. Mataas yung kanyang brain natriuretic peptide or yung kanyang pro-BNP. Mataas din yung kanyang CVP, yung central venous pressure, na may measure kasi yon. Evidence of left-sided heart failure, okay? Evidence of positive fluid balance, and radiographic evidence of pulmonary edema. So sa TACO, basta sobra-sobra yung naibigay sa kanya, nagkakaroon siya ng circulatory overload. Yun yung, tapos na kakatransfuse. Okay? So, kaya siya tinawag na TACO. So, rate of infusion is also an important factor. Pag masyadong mabilis daw yung pagkakatransfuse ng fluid, okay, pwede siyang magkaroon ng TACO. Number 6 is transfusion-associated dyspnea. So dyspnea or shortness of breath in allergic reaction, TACO or TRALI diagnosed within 24 hours post-transfusion. The cause is unknown naman. Okay? So hindi ko pa masyadong na-encounter itong transfusion-associated dyspnea. Number 7 is hypotensive transfusion reaction. So it is diagnosed when hypotension is seen alone during or within 1 hour post-transfusion. Paano malalaman? Kasi every 15 minutes, bini-BP dapat yung mga pasyente or yung mga recipients habang ongoing yung transfusion. So, the criteria is there is a drop in blood pressure. For adults, the systolic systolic BP of more than or equal to 30 millimeters mercury is considered a hypotensive transfusion reaction. So kunwari 120 yung kanyang initial or yung kanyang baseline, 120 millimeters mercury, tapos nung binipi ulit ay naging 80 millimeters mercury. Okay. So it is considered a hypotensive transfusion reaction. Pediatrics naman, okay, if 25% or more drop in the baseline systolic function. Okay. So the hypothesized cause is increased bradykinin level in the stored blood. Yung bradykinin kasi is, ano yan, para siyang relaxing factor. Okay? So pag masyadong na-relax yung mga vessels, bumababa yung pressure. Okay? That's why you have hypotensive transfusion reaction. Number 8, is the most common. Okay, you have your febrile non-hemolytic transfusion reaction. Here, this is the most common adverse transfusion reaction in RBC transfusion.
Nag-release ng lab na chief resident sa Zoom.
So in febrile non-hemolytic transfusion reaction, this is the most common adverse transfusion reaction in RBC
So I would just like to
transfusion.
ask, sa cutting department ba, do you refer to your IDS just to ask?
So it is defined as an increase in baseline temperature by 1 degree Celsius, okay, or 1.8 degree Fahrenheit during or within 4 hours post-transfusion with or without chills. Okay, so kapag tumaas, kunwari ang baseline niya ay 36 tapos naging 37, okay, or 37, it's considered a febrile non-hemolytic transfusion reaction. If the rise naman in temperature is 2 degrees, okay, 2 degrees or higher, it is considered a transfusion transmissible bacterial infection, TTBI. Okay? Transfusion transmissible bacterial infection. So kung kunyari ang baseline niya ay 36 tapos naging 39 degrees Celsius, yun, considered siyang TTBI. Okay? The cause is recipient's anti-WBC antibodies. Okay. So blood products with increase in leukocytes and platelets are prone to cause febrile non-hemolytic transfusion reaction. That's why, sinasabi ko kanina, the importance of yung leukoreduce, okay, leukoreduce packed red blood cell, wherein you will remove the WBCs because the recipient will form anti-WBC or anti-leukocyte antibody. Okay? Para ma-prevent yun, dapat wala kang introduce na WBC. Kaya i-filter out mo yun. Okay? Number 9 is allergic transfusion reaction. So this is the most common reaction seen with platelets and plasma transfusions. So it can be mild to moderate signs and symptoms limited to the skin and GI. So yung iba parang nangangate, yung iba parang masakit daw yung tiyan, okay, yung iba parang natatae, ganun. Anaphylactoid naman is a moderately severe that includes oral and throat symptoms, more severe GI symptoms, and respiratory complaints. So dito, kapag anaphylactoid na siya, allergic transfusion reaction, mahirapan na siyang huminga, masakit yung dibdib niya, yung mga yun. Okay. So for anaphylactoid reactions, the criteria is present during anaphylactoid reaction signs and symptoms present during or within 2 hours post-transfusion. So mabilis lang sila. And exclusion of other causes like drugs, environmental, and dietary factors. Okay. And the cause is IgE-mediated hypersensitivity. So as you all know, IgE is the mediator of hypersensitivity, okay? Or this is your type 1 hypersensitivity reaction. Okay? If it is very severe, we call it na anaphylaxis or anaphylaxis. Okay? Dito, ang gagawin na is tutusukan na yung pasyente ng epinephrine. Okay? Number 10 is transfusion-associated graft versus host disease. Okay, so the criteria is a clinical syndrome developing from 2 days to 6 weeks post-transfusion. So patients develop rashes, fever, diarrhea, hepatomegaly, elevated liver enzymes, marrow aplasia, and the definite diagnosis is by skin or liver biopsy, wherein the histologic features, there is superficial chronic inflammation and vascular changes at the dermo-epidermal junction, okay, in the skin with single cell necrosis of keratinocytes and lymphocyte satellotosis. Okay? So I have not encountered one, okay, but this is the criteria. Okay? The cause is recipient immune status, component characteristic, and donor-recipient HLA relationship. Okay. Number 11 is post-transfusion purpura, severe and sudden drop in the platelet count occurring 5 to 10 days post-transfusion. Here, alloimmunization to platelet-specific antibodies from prior transfusions or pregnancies. Okay. So, for the criteria, there is thrombocytopenia to less than 20% of pre-transfusion count and demonstration of alloantibodies to platelet. Okay, so meron kang alloantibody na HPA1 or HP3A. Okay, so yun yun. So yun yung cause ng post-transfusion purpura. Nagkaroon ng rashes yung pasyente. Okay, tapos bumagsak yung kanyang platelet count to 20% of the pre-transfusion. So kunwari ang kanyang platelet count nung una ay 150, pinakamahal 100. Tapos bumaba ng 20%. So naging 80 na lang yung kanyang platelet count. You consider that. Tapos meron siyang mga rashes. Okay, you can call that your post-transfusion purpura. Okay. Next is platelet refractoriness and alloimmunization. So I've mentioned this earlier. Patients receiving multiple platelet products that cannot achieve expected increments in platelet count. Okay. So alloimmunized to HLA antigens and platelet-specific antigens. So yun yung cause niya. Adverse metabolic effects of transfusion. Okay. So example will be citrate toxicity and hyperkalemia. Okay, so you expect that with multiple blood transfusions, okay, multiple na whole blood or basta basta may plasma pa, okay? Kasi nandun yung citrate. Whole blood, FFP, mga ganyan. Magkakaroon ka ng citrate toxicity. Pag hyperkalemia naman, yung may mga red blood cell. Kasi doon galing yung potassium, doon sa mga nasira na red blood cell. So citrate binds to calcium and magnesium to prevent activation of your coagulation factors. Okay? Metabolic alkalosis can develop from bicarbonate produced from citrate metabolism. Hyperkalemia naman, on the other hand, is potassium leakage from aging red blood cells. Okay? So it is a major concern in neonates than in adults because if you have hyperkalemia, the patient can go into cardiac arrhythmia and then later on to myocardial infarction. So baka yun pang ikamatay niya, yung transfusion, hindi yung totoong sakit ng pasyente. Okay, 5-minute break ulit before we proceed to the final topics of our lecture this afternoon. Okay, so konting-konti na lang and you can ask your questions later. 5 minutes. Okay, sige, tapusin na natin para matapos na. Okay, let's proceed to transfusion-transmitted diseases. Okay. So number one is donor testing. Okay. So in the Philippines, we are required to test for HIV, hepatitis B surface antigen, anti-HCV, syphilis, and malaria. So this is mandated under the DOH Department Circular 2013-0132A. Okay, so ito yung minimandate niya na lahat ng blood units ay i-test natin. Okay. Sino bang nandyan? Christine de la Cruz. Christine, are you there?
Yes po.
Oo. Question. Kunwari meron tayong isang, may kamag-anak tayo na nangangailangan ng dugo. Tapos, galing siya sa galing siya sa Red Cross. Sabihin na natin galing sa Red Cross. Tapos, dinala doon sa hospital kung saan naka-admit yung kamag-anak natin. Ngayon, yung kamag-anak natin, ayaw niya na matransfuse yun hanggat matest ulit. Ite-testing ulit yung dugo niya. Ay, yung dugo na yon para ma-sure na wala yung sakit. Okay. Pwede ba yon? Nakuha mo, Christine?
Yes, sir. Parang you will test again the blood
Oo,
coming
oo.
from Philippine Red Cross.
Oo. Pwede ba yon? Can we insist our demand to retest the blood unit prior to transfusion?
So here are the results of the laboratory sa admission.
I'm not really
the patient
sure,
has noted
sir, if
bandwidth of 0.22.
kung pwede
The patient
siyang
of 440.
i-retest again
So
since it's
on the
very
electrolytes, we noted a hyponatremia of sodium
Since
of
it is
129.2. Potassium of
parang
2.8
dagdag
with
gastos
a
siya,
normal
sir.
condition.
But I'm not really sure, sir,
CA
kung
was
pwede
done
siya
for
ulit
normal
i-retest.
of 2.88.
Pero yung kamag-anak natin yung
Chest X-ray at this time.
namimilit na i-retest. So wala siyang pakialam sa gastos.
Siguro, sir, pwede.
Pwede. Okay. So the correct answer is hindi na pwede. Okay? Hindi na pwede. So there is an order coming from the DOH that retesting is not allowed. Okay? Retesting is not allowed. This is the DOH Department Circular number 2018-0348. Okay? Department Circular number 2018-0348, wherein reiteration of no retesting policy of blood units and the set maximum allowable service fees for whole blood and blood components in blood service facilities. Okay? So, bakit ko tinatanong? Kasi common yan na
Divided into about 330 grams of protein.
common yan na tinatanong sa mga hospital na ayaw kong i-transfuse yan hanggat i-retest nyo. Okay? So, ang mandate kasi ng DOH is, ang sinasabi niya, dapat yung testing, yung pang-test din natin ng mga TTIs ay halos pare-pareho. Okay? So, hindi na rin pwede yung magte-test tayo using test kits, yung mga lateral flow test kits, hindi na pwede. Okay? So, dapat quantitative testing na tayo using EIA, CLIA, yung mga ganun. Or other methods. So in other countries, as I've mentioned earlier, they are testing for anti-HTLV 1 and 2, anti-HBC, trypanosoma, Zika virus, and West Nile virus. Okay? We can also consider this as transfusion-transmitted infections, but they are not usually tested. EBV, CMV, parvovirus, B19, Ebola, chikungunya, Babesia microti, Leishmania, Donovani, and prions. Okay? So, yeah. In terms of transfusion-associated hepatitis, okay, so there is a diagram there. You know this already. Okay? So, pero sadly, in our country or in our setting, what we test only is your HBsAg and anti-HCV. So what if the patient is in the window period? Okay? What if the patient is in the window period? Na wala kang matetest na antigen, wala kang makikita na antigen, only your anti-HBC IgM. Okay? So if you will not perform anti-HBC IgM, merong makakalusot. Okay? So during my residency, one of my study is ano kaya ang probability na merong blood donor in tawag dito, in the window period. Out of 200 donors ata yun, may isa. Buti na lang hindi pa siya na-transfuse. Tapos, na-discard na yung blood unit. And we called the donor and we advised him to undergo treatment. Okay? So, yun. We're almost done. Okay? So, HIV types 1 and 2. Okay? So, there is the diagram there. For syphilis, okay. Yan. And for malaria. Okay? So we will not focus so much on this, your TTIs. Okay? Just as long as you know that HIV, hepatitis B, anti-HCV, syphilis, and malaria are being tested, and no retesting policy is in place, and the methods for testing should be qualitative and not quantitative. Okay? So do you have questions for this afternoon and for our morning's lecture? May question ba kayo? Before we end this session. Kasi kung wala kayong question, sa quiz na lang tayo magkikita. At saka sa comprehensive exam nyo. Okay? Medyo mahirap yung exam nyo.
Good afternoon, sir. Sir, kailan pang complete kapag to?
Ano, sorry? Meron? Desiree, pakiulit. Ano yun? Desiree, ano yun ulit? Pakiulit mo nga. Sorry, napuputol. Pakiulit, isa pa.
Sa sakali.
Ano? Naputol ulit eh, sorry. Isa pa.